All right, I get to the honor of introducing our keynote speaker for lunch. And that's the joy that Ellen and I had of being co-chairs for the committee this year, as we got to pick the speakers and organize the sessions. And so that was actually a lot of fun to do. So it's my pleasure to introduce Dr. Lisa Simpson and give a little bit of a background on her. I'm not going to give a lot. I know we're running behind schedule, and I don't know that I have the, but basically, her undergraduate work and medical degree was at Trinity College in Ireland. She has an MPH from the University of Hawaii and did postdoc work at UCSF. She was a professor of pediatrics at University of South Florida, the director of Child Policy Research Center at Cincinnati Children's Hospital and University of Cincinnati. She was a deputy director for the Agency for Healthcare Research and Quality. And since 2011, she is the president and CEO at Academy Health. She is a nationally recognized health policy researcher and pediatrician. Her specialization is translation of research into policy and practice. And as we reviewed her file and her literature, we thought what a perfect person to host this keynote at the CCTS, where our mission is translational research. So with that, please join me in welcoming Lisa Simpson.
Okay, I'm shorter than that. Okay, because I got to be able to see the computer too. So this is a hard act to follow with all that recognition. Okay, oh well. I should have done my Donna Shalala trick, which is to bring a riser so you can actually see my body as opposed to just the top half of my head. But I want to first start out by saying what a pleasure it is to be back here in Lexington. And I used to come to the Keynote conferences with my colleagues Glenn Mays and Doug Scutchfield, and it was always such a pleasure. And it was great to see them again, and it's been great to be here all day, and I can chide some of you for saying you missed out a really good talk this morning. The opening keynote was fantastic, and it makes it a hard act to follow, and I'm a little short on time, so run along with me as I go through my remarks, and hopefully some parts of it will resonate with you. Okay, let me get my slides up. I assume they're here. So while I'm doing this, let me try to multitask and ask you, how many of you are clinically prepared? Docs, nurses, pharmacists? Show your hands. Okay, how many have PhDs in something other than the three disciplines I just mentioned? And how many of you are something else? I mean, there's so much you could be, right? I mean, masters and all the research managers and the fabulous infrastructure that doing translational research needs. So my talk today, as you can see up here, is talking about some new directions. And I hope to cover quite a bit here. First of all, how many of you have ever heard of Academy Health? Oh, that's a better show of hands. I do this test everywhere I go. So I'll tell you a little bit more about us, because that informs my perspective. And one of the things you learn early on in translating research into policy is that the messenger is very important for how the message, i.e. evidence, is received in the policy discussion. So I want to tell you a bit more about us, the role of evidence in policy, the role of data, networks, and innovation. And then finally, if we have time, I have some reflections on the lessons learned by me along the way. Even though I can back them all up with a big literature, because this is a science policy and a science conference, that's my qualitative component that I'm bringing forward. And of course, I have to start any talk like this by acknowledging and remembering a great mentor of mine, since we just had the Mentor Awards, John Eisenberg, who was the director of the Agency for Healthcare Research and Quality. And he used to talk about, you've probably heard the saying, if you see a turtle on a fence post, you know he didn't get there by himself, or she didn't get there by herself. And so there were a lot of people behind the fence post helping me along. And also, I'm here sort of as the national voice for our field of health services research. So I really want to acknowledge all of their contributions to my talk and the work that I do every day. So Academy Health is the National Professional Society for Health Services Research. I'm not going to read these, but the point of our mission and vision is that we're all about evidence in decision-making to advance health and the performance of the health system. So not just producing that evidence, but also translating it. So that's what gets me up in the morning. It's what lights the fire in my belly. And so we work with our members and our partners around the country to build a diverse and vibrant community, to advance the science of our field, and to promote its translation into action. And we have over 4,000 members, individuals and organizations, and obviously we're a very big tent field, very multidisciplinary. And so we have lots of little tents which are gathered around interest groups, councils, and other ways to work together. So if you haven't joined or are interested, I have to do the pitch just like the CCTS and ask you to join Academy Health. And we're best known for our conferences. So one, we do in partnership with the NIH. And if you're interested in this translational aspect, you may want to come to this annual conference on the science of dissemination and implementation. We had 1,300 last year. It's been growing every single year. It's robust. It's NIH supported. Most of the investigators there have NIH support. Our National Health Policy Conference is where, again, we push that evidence into action through public policy. We have the Data Palooza, which is our newest conference focused really on how data and innovation is transforming our ability to not just use evidence, but actually produce it, and I'll touch on that. And then finally, the jewel in our crown, our annual research meeting with over 3,000 people, which will be in DC this year. So with that, that's the quick, pitch for Academy Health, and it grounds the rest of my remarks. So this is a CCTS conference. I was involved with the Cincinnati CTSA, so I wanted to ground us back in the 3 Ts. I assume you've all heard this framework. And health services research is squarely in the T2 to T3 realm. And policy research, which is then taking all of this research and trying to use it in the policy context, is certainly in here as well, more as T3. So what is health services research? Well, I like to say the actual definition is longer than my lung capacity, even on a good day, could get out in one breath. And so what I tend to use is this definition. If you're thinking about what works in healthcare, for whom, for both systems, policy, individuals, and under what circumstances, that's a learning that's really strengthened by our focus on dissemination and implementation research. Context is, they say content is king. Context is the queen. How the context where you are trying to implement something really has to inform your implementation strategy. And then once we know what works, I think one of the big limitations of our field and our country writ large is that we have a lot of evidence. We're not very good at systematically implementing it, taking to scale, and sustaining it. And that's where policy and systems change really comes in. We heard this morning about just what a difference tax policy makes to tobacco use and could make in this country. We haven't done it yet on sugar-sweetened beverages and other ways of driving, the nudge behaviors of behavioral economics towards healthier behaviors and eliminating the NCDs or non-communicable diseases. So that's what we think about in terms of the breadth of health services research. And if you don't do this now, there is money. Now, we're not as much money as some of maybe the basic scientists receive, and I know your application for your CTSA renewal just went in, but we have a whole update on health services research in our premier journal, HSR, that came out at the end of 2017, where we also did an analysis and documented the increase in funding, which is still predominantly NIH, and I think still not enough given how much we spend on healthcare overall. If you think about other sectors of our economy and their investments in R&D, healthcare invests far, far less in improving its performance in the marketplace than we do in healthcare in this country. And don't forget, public purchasers are the biggest purchasers of healthcare. So we're buying, taxpayers, we collectively are often buying, excuse the English, crappy care. And so how do we get better value for our dollars in the research by bringing research into policy? So now let's turn to how evidence is actually used in policy. We heard great examples again this morning of very specific strategies to get evidence used for policy, but more importantly, evaluating the impact of policy. So let's talk about the many ways that evidence can inform policymaking. But before I do that, what do we define as policy? When you say the word policy, most of us tend to think of the nation's capital. Just let that sink in. Today, we're in the real world. I'm here in Kentucky. So let's not forget that part of policymaking is also state policy. And I attended the morning session on the State University Partnership Learning Network with a number of fantastic researchers and findings. And there are many, many ways that state policy levers can take evidence and actually use it, not just for tax policy, as again we heard this morning, but in terms of regulatory policy, licensing. We have a number of nurses in the College of Nursing here. We've had a number of instances, states using outcomes research on nurse staffing ratios and other research to inform licensing, et cetera, and regulations. And with this, over the last 10 years, with the implementation of the Centers for Medicare and Medicaid Service Innovation, CMMI, the state, the SIMS, the state innovation models. Does Kentucky have a SIM? Okay, I don't know. The massive grants for states, that's another way that innovation can be driven by state policy, and obviously we'd like evidence to contribute to that innovation and help inform it. Because remember, all improvement is change, but not all change is improvement. And a big part of health services research is trying to understand which changes actually yield and result in the intended outcomes and what are their potential unintended consequences. At the same time, policy is also made in the private sector. So my sense of when I talk about policy, it's really across all three of these. I remember the days, one of the things that wasn't mentioned, my first real job out of my 2 residencies was I was the state director for maternal and child health in the state of Hawaii. I like to pick nice places to live. And even if I did my job fantastically and optimized all my services, my biggest reach because of the state population was maybe 600,000 women and their kids. Whereas, United Health Group, how many people do they insure? What is the potential for making a difference in terms of the quality and range of services through a health plan? So tremendous potential to improve and inform private policy. And it's important to remember, while we talk about evidence-based policy, the reality is many other factors play into the ultimate policy choice that is made. And we are very aware of the part here of political actions and preferences. Our values are very much a part of our decision-making process. And so what we bring is evidence, what we hope to do is evidence-informed decision-making, at least consider the evidence as part of that choice, which, if you think about it compared to clinical care, when you're recommending a treatment to a patient, a therapeutic regimen, you are also hopefully weighing their values and preferences and engaging in shared decision-making, and hopefully, always weighing evidence first, but if there are a range of alternatives, also taking these others into account. So, as you can see, I'm an optimist about the use of evidence in policy, or else I wouldn't be in this job. And so I would argue that it's not, whether evidence is used in policymaking, but how it's used. And there's an extensive and robust literature over the last 40 years about this point. And I think we're most familiar with the symbolic use, right? I have this policy I want to promote. Go find me the data to back it up. Go find me the evidence. So it is being used whether we like it or not, and some researchers found out the hard way about the misuse of their research evidence. So for example, some researchers showed that I think they were Florida, well, the policy was changed in Florida, I'm not sure where this research came from, that if you reduced the paperwork burden to re-enroll children in CHIP and made re-enrollment either automatic or very rapid, enrollment rates went up. Well, guess what? When state budgets were cut, they reinstituted all those things because they knew enrollment would go down. So again, your evidence can be used in a variety of ways. Conceptual uses is also something we tend to forget about. And what I mean by that is how evidence can help change the way we think about the challenge. So the classic example of this is patient safety. It was sort of, there's always, X rate of complications for whatever procedure or treatment. But the report, the IOM report to Err is Human said, hey, wait a second, there's a whole lot more to safety and medical error than just the natural expectation. And so it changed the way the country thought about patient safety and medical errors. And then finally, I think the use we're most familiar with and talk about the most is instrumental use. And that's when we use research to inform a specific step or decision in the policy process. So first of all, evidence is used to document and monitor trends. We heard some of that today in terms of the impact of different strategies on opioid use and its reduction. So you're just documenting, monitoring. That's how we know what progress are we making. It's also used to identify and understand. For example, we all are very aware of the pervasive and persistent disparities in health and healthcare. But we've gone in that research body from just documenting and monitoring to then also trying to understand why these happen. What are the root causes? Because you cannot develop or test an intervention, the next step, until you really understand the root causes. Then we want to translate and use that information, and again, that gets back to the dissemination research, implementation research. How do you do that effectively? And then finally, how do you evaluate and report on the policy change itself? Did it work as intended? And if not, why not? So here's an example of also, this is drawn from a survey we did in 2015, so it's a little dated. I'd love to repeat it, but this was when we surveyed state program policymakers. So these are not necessarily the elected officials, but a lot of the senior executive branch leadership on how they used evidence. And we asked that question for 5 stages of policy development. So first, as I mentioned earlier, understanding the scope and extent of the problem. You'll see the numbers there in front of you. More than three quarters report they use evidence. Developing the policy options. Well, I could do this, this. What evidence do I have about the relative effectiveness of my choices? Implementing the reform, much less in terms of day-to-day program management, not surprising, and then again, evaluating the policy. So these are state users. Probably, this is not a random sample. I'm not saying this is representative of all, but again, don't forget that using evidence to inform policy, there are many steps during which you can use that evidence to make important changes. And one of the other things I found interesting in this survey is that when we asked the states where they turned to evidence, we all know about the second or third, policy analyses briefs. If you haven't had some training on how to do your one-pager for policy and what's your soundbite and how to communicate, that's really important, but I was surprised how many of these state users quoted systematic reviews, and I think this reflects the growing sophistication of folks that, it's not just one data point and one study that should guide policy decisions, because we don't want policy whipsawing back and forth. It's really hard to change legislation once it's enacted because you create all kinds of stakeholders, and it's very hard to change regulation, another type of policy making, once it's enacted, again, because there's a whole regulatory bureaucracy that needs to be gone through, thankfully, with public input. So you really want to make sure that the body of evidence is telling you directionally where you should be headed. So that's another important point. In terms of what affects the use of policy, this is a less current reference, but again, it's consistent with current research. I must say, sometimes I'm a little frustrated by how much research keeps getting published about how hard it is to translate research into policy. Let's do more intervention studies on how to do it better, and I'll mention that. But factors that affect this are obviously the pertinence or relevance. Pertinence, the Canadians like to use that term. The relevance of the study, its ideological acceptability. Yes, we talked about taxes and how the word tax turns some people off immediately. So how is the policy, what parts of the policy apparatus is this calling upon, and how acceptable is that? Also, its practicality. If this means changing a whole host of regulations, it's going to be very hard to make that happen. So yes, simple fixes do sort of happen much quicker in policymaking. And clearly time urgency feeds into this as well. Decisions must be made. If it's going to take you a year to get an answer to a policymaker's question, they will make the decision regardless. So that time urgency creates the sort of two communities problem that were first described in the 70s of the culture of research and the culture of policy. And then the other part is obviously power and interest group dynamics. Everybody has evidence now. everybody goes to their policymaker with their data, with their evidence. And so power and interest group dynamics really play out here. So there's an old saying in Washington, if they like what you're saying, you're called a stakeholder. If they don't like what you're saying, you're an interest group. So lots of adages in Washington. And then finally, what I said at my first point, which is the messenger and the message frame is really important. And message frame means how is it presented? And if you've read Rob Kahneman's Thinking Fast and Slow, I mean, we have all these cognitive shortcuts. And so we react to even how it's framed and the words that are used. And so we need to think about that. And I'll show you specific examples of words in a couple slides. But all of these affect whether or not your evidence is going to be informational and useful and potentially influential in the policymaking process. So I talked about wanting to see more understanding of, instead of describing the challenges of using evidence in policy, research that looks at how to promote the use of evidence in policy. And the W.T. Grant Foundation has been doing quite a bit of work on this in the last decade. First, they sponsored a whole portfolio of studies to really try to get into what does affect the use of research evidence in policymaking. And so there's this wonderful report, it came out, I think, last year, sort of quantifying some of the lessons learned across the portfolio. And now they're sponsoring studies to study the implementation, how to promote the use. So they spent some time studying what drives it, and now they're sponsoring studies on how to get its use accelerated and expanded. And I'll tell you, they're really hard grants to get. We've been called into a couple grants. They're very, very rigorous, and they're cross sectors, not just health, but also education, social justice. They're focused on youth. And so they, what are the various influences on research use? They outline this, the various targets. Who are you trying to get to use this evidence? Because how you do it and your strategy varies very much based on the target. And then, how do you counter or manage claims about research use? And then this report outlines, I think, some really important recommendations. The first one, when I first read the report, I was like, okay, wait, let me reread that. And it's really bringing critical social theory, and particularly around issues of disparities, we need to pay attention to the context and the institutions and the structural racism and the sort of history of those institutions over time to this question of the use of research evidence. They also said we have to address the quality of this research. One of the things they conclude is that far too much of this research is just case study based. And so, that's important, and that gives you a really rich and deep understanding of those instances, but we need to broaden it to much broader and more rigorous designs to be able to generalize more effectively. They also talk about the various methods and measures, and if you didn't know, there are lots of measures out there that are validated measures to study research use for different types of users. So I encourage you to look at that. And then to create methods templates, because too many researchers are just saying, oh, there's nothing out there, I'm going to create a new measure of research use. Well, there are standard domains and there are templates that they've created. So if you're thinking about developing a new measure, it doesn't mean it doesn't need to exist, but go look at these templates and see what already exists, which I think is really important, because we've, in the last 20 years, certainly in the quality measures world, we've seen a proliferation of measures, which of sort of what I like to call boutique measures, and they're great, and you get funded to develop a new measure, but then we have, again, the generalizability, multi-site research issues. And then finally, research reporting guidelines. You've probably heard of all the various reporting guidelines that exist for other types of research. Well, there aren't any in this domain. The next area of using research evidence that is, I think, an important development, again, my optimism makes me hopeful that it will make a difference, is the commission, this report that came out in 2017, and upon which the Evidence-Based Practice Foundations Act of 2018 was passed. And one of our members, Sherry Gleed, was a co-chair, and it's a terrific report. And this is a summary from the Bipartisan Policy Council about the legislation and what it calls for. And in one of the conclusions that was made by somebody from the University of Nebraska, which is summarized in another brief, is agreement and support for legislation to expand access to federal data and promote the use of evidence to inform policymaking is a positive development in a political environment marked by fierce debate on the relevance of facts and expertise. Certainly, we've all been very concerned about the politicization of facts and evidence, but this is a pretty positive development. The report espouses a number of different principles, which I think are important to sort of touch on as we think about how to use evidence in policy. Obviously, if we're going to promote more data use, we have to ensure privacy. If we're going to use this evidence to make sweeping decisions that affect thousands, hundreds of thousands, if not millions of people, we have to make sure we are doing rigorous research. Because another adage in Washington, if they don't like your findings, they will get you on your methods. So make sure you're using defensible and excellent methods. Transparency, this is not the only sector where we're finding increased demands for transparency from government, and so that principle is also reflected in this report. Humility, this is probably my favorite principle, that we've got to be careful about sort of our degrees of certainty and the generalizability from any study that we present. So we don't want to go up and say, caveat, 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 but this, limitations that, you'll lose your audience. But you also have to bring that humility of your findings because some researchers become real policy entrepreneurs and they're pushing a certain policy using the research they've done over their entire career. And we, as a research community, can get ourselves into trouble when we do that. And then, capacity. The capacity to generate and use data is also not as good as we would hope. So the report called for 3 main areas of action: improved access, stronger privacy protections, and again, greater capacity. Specifically through creating learning agendas, a chief evaluation officer, coordination of evidence building. Good luck with that. That's hard. I worked as 9 years at the Federal Department of Health and Human Services. Talk about people having agendas and silos. Coordination is critical. It's got to happen, but it's, you got to understand organizational change management as well and dynamics of internal politics. Aligning administrative processes, and then obviously always the big bugaboo when you're looking at a federal budget is sufficient resources to actually implement the recommendations. And again, Dan and Bring said 10 of the 22 recommendations were included and concluded that the act is an important first step in the intentional and systematic use of data and evidence to develop, evaluate, and improve federal policy and programs. So again, for those of you who are cynical and think that evidence is never used in policy and there's no point in trying, you are wrong. And in fact, one of the things you may not know is that part of the role of evidence in policy is making sure bad policy doesn't happen. Stopping a bad idea from a leader in the executive or legislative branch. There's this whole sort of science and policy evidence apparatus in the Office of Management and Budget, in the White House, the Domestic Policy Council, the Council of Economic Advisors, and they say, thank heavens that exists because there are a lot of bad ideas out there, and we bring evidence to those. So it's just like prevention. You may not see the impact. It's hard to quantify. So turning from that to the role of data, networks, and innovation, there are certain areas I want to touch on here. It is by no means exhaustive, but I want to give shout outs to a couple of initiatives and new developments that I think are particularly important for a CTSA, CCTS, getting your acronym right. So first, let's talk about networks. Well, first of all, networks can overcome data sharing limitations to do more research. So how many of you have heard of Odyssey? Oh, not too many. Okay. So this grew up grew out of the OMOP program from NIH, and it's I can't even remember how many sites. It's a global, collaborative, open source network that's really promoting outcomes research and observational research. That's what the O stands for. There's another network of networks that we helped to co-found called All In for Community Health. Anybody active in that one? Okay. Well, this is a great network which is really focused on population health and sharing data across sectors. So health data, transportation data, housing data, all of these other data sets which are now not easily, but becoming available for better understanding the upstream social determinants of health and other factors that drive health outcomes at the population level. We also were helped to launch the National Interoperability Collaborative with Stewards of Change. This is a collaborative to look specifically at data sharing across health agencies at the state level and county level and human service agencies, again, to optimize health and outcomes and program efficiency and all the other factors that the administrators for those programs care about. And then one of the networks that we're proud to sponsor is the State University Partnership Learning Network. It's a horrible acronym, right, Jeff? SUPLN. We couldn't think of a good name when we launched it, and we thought this will never last. Well, we launched it 5 years ago. It's still called SUPLN. So it is what it is. And we now have 27 state health agencies, and often the Medicaid agency, like in Kentucky, and Kentucky is one of the newer ones. We're delighted to have Kentucky in the network, and their state university partners. And we just recently had a strategic planning session with the steering committee, and we're very excited about the future. There's always, since the Affordable Care Act, there has been even more focus on state action. I mean, we've always been a country of federalism and devolution to states for decision making. But since the Affordable Care Act, and now with this administration, a focus on state decision making is really top. And so the SUPLN is a great way for Academy Health to help support, again, the development of more evidence. And so one of the things that the SUPLN did was help to launch the Medicaid Outcomes Distributed Research Network, or MODERN. Now, isn't that a better acronym? I'm trying to keep you guys awake. You just ate. All right. And so this builds on our State University Partnership Learning Network. It's a subset of states. I think 10 states participated in the first project, which was around opioid use disorder, because high priority for their state partners and a dearth of understanding the performance across various different states. And so we really learned from the PCORE-NET model as well as Sentinel about how to do a DRN. So if you don't know what a DRN is, it's distributed research network, and a DDN, a distributed data network. So you'll see this is the basic organizational structure, but importantly, the coordinating center is not a big data vacuum. It's not taking in all of each state's individual level data and performance. It takes their analyzed results, which, as you can imagine, with every state's DUA agreements, it's a huge barrier-busting approach, incredibly relevant for state policymakers, because negotiating data use agreements with every state is hard enough for the in-state university partners. It's even harder for out-of-state folks. So you can see it establishes a common data model. Each of the analyses are conducted locally within each, and then the data coordinating center distributes the code, and they execute and then share the data back. The second purpose of networks is not just creating new data in ways that couldn't be used for informing policy, but support the use of the evidence once it's created. And so we have another network, I sort of alluded to it, which is the Medicaid Medical Directors Network. And Gil Liu, who, if he's still here, has been the Kentucky Medicaid Medical Director for a number of years, and I know Kentucky's very sad to see him go. But this 43 states have Medicaid medical directors. This is the senior physician, MD or DO, in the state, and we've been convening them initially with support from the Agency for Healthcare Research and Quality for over a decade, except for a 2-year hiatus. So an incredibly tight network where we have a number of activities. The other one, I'll tell you a bit more about MMDN, but then the other network, this is not just a U.S. phenomenon of doing networks to support the use of evidence. We're also Academy Health is also part of an international network called LEAP Forum. The WHO Alliance for Health Systems and Policy Research launched in 2016. And LEAP, again, it's one of those acronyms. It's there, maybe you can read it, it's too small a print for me, but it's about leveraging evidence and advocacy, the use of evidence in policy. So networks are certainly useful in promoting the use of evidence in policy. And you'll see here our Medicaid Medical Directors Network has been doing a range of work with CDC on promoting the uptake of HIV PrEP, on immunizations, and also looking at core, CHIP, and child and adult core measures in the Medicaid program. So the other aspect of this sort of part of my talk is the focus on innovation. And how many of you have heard of the 21st Century Cures Act? Okay, good, a good number. So I'm just extracting tiny little bits of it. But again, to say that there's a tremendous innovation happening because of the transforming data infrastructure, but also because of the changing acceptance of the need for patient engagement in research. And obviously you have a community engagement core, you're doing some of this. But one of the FDA provisions is about patient engagement and collecting patient experience data and a whole set of guidance around patient-focused drug development and reports on patient experience in drug development. And so this report came out just last year. I encourage you to look at it if you go to the FDA website. But that's certainly an aspect of innovation that we're going to see more and more of because of these authorities. The other thing I would say is that historically the field of health services research has not really been in the regulatory science space of the FDA, but with the changing data infrastructure and the advent of digital health, increasingly our worlds are coming together. So FDA is going beyond the phase 1 to 4 trials in thinking about drug development. So it's a real opportunity. The other part of the act that FDA is implementing is around digital health innovation. Now, this report, again, also just came out last year, and FDA was already starting to move in this direction, but this report covers what the forthcoming guidance on, how they're going to regulate and what types of evidence is acceptable for various types of medical software organizations, devices, your Fitbit, the Apple EKG, you name it, a whole host of new innovations and products on the market. They're also reimagining their oversight with this sort of the way they regulate and will deem companies and approved, and then also strengthening FDA capacity. And then finally, their real-world evidence framework. Again, a recent report. This report defines both what is real-world data and real-world evidence, and then outlines key elements of the framework that FDA is using to think about when and how it will accept real-world data and real-world evidence into the safety and effectiveness and regulatory decision-making. So this is, sort of watch this space. There is a lot happening with the 21st Century Cures Act, and that creates a lot of opportunity for how we use different kinds of data to inform a different kind of policy, regulatory policy. And just to end this part on FDA, Scott Gottlieb said, as the breadth and reliability of real-world evidence increases, so do the opportunities for FDA to make use of this information. So I think that's a very clear signal. Many of us were sorry to see Scott go, but the number 2 at the FDA until they appoint a new director is Amy Abernathy, who's a fabulous health services researcher and oncologist, came to FDA from Flatiron, and before that was at Duke. Sorry, she was at Duke. But again, I think there's tremendous opportunity in this space for translational research. The final aspect of my talk that I want to touch on is sort of bringing it all together. What are some lessons learned, some reflections that reflect both my successes and the scars that I've sort of accumulated over a few decades of doing this work. And so there's an asterisk next to 6 because I have more than that, but in the space of time allocated, I picked my top 6. And so they are: make sure it matters, keep it simple, stupid, Timing is critical. Learn to play the long game, build trusted networks, and use the power of narrative. Media math, anybody ever heard media math? This is during media training. You tell the audience 3 points. You repeat them 3 times, they will remember 1. Okay, so I want to let you pause and look at that for a second, and I want to give you some examples of each of those lessons. But again, there's a robust literature that backs up each of those points, and these are my sort of lived experience on using them. So first of all, making sure it matters. So Academy Health gives an impact award, which is for research, a body of research, whether it's one paper or a series of reports that not for their potential for impact, but have actually changed policy. And so this impact award went to Terry Tennelian and her colleagues just over a decade ago, looking at PTSD and suicide and mental health in our veterans. And so they found, we all knew this was a growing issue, but they put a number on it. Again, numbers are really important in the policy space. 18.5% had symptoms consistent with PTSD or depression. 19.5% had a TBI, traumatic brain injury, and about 50%, only 50% sought care, and only 50% of those actually received minimally adequate care. So we're talking 25% getting what they needed to address their mental health needs. So what impact did this have? Well, first of all, they got a lot of press coverage. If you're trying to inform policy, the media is your best friend. Yes, even social media. I became a tweeter when I went to Academy Health. They didn't just stop with the report and the published findings in a high-impact journal. They did congressional briefings, executive branch briefings. They brought veterans in with the stakeholders, so the people this is about. They did direct-to-consumer education for veterans themselves and families. And what did that lead to? Over time, this was not easy. It took time. They got significant policy changes with security clearance modifications, mandatory screening, and then a real transformation of care. And that continues today with more and more initiatives to support improving the mental health care for our veterans. The second lesson is keep it simple, stupid. So I already mentioned this report. And the IOM produces, now the National Academy of Medicine, produces lots of reports. Most of them, I mean, I'm a member, I'd say most of them, they don't have the impact you hope they are going to have. They're roundly ignored, or maybe they always inform the future research and us. But what policy direct sort of thread between the report and policy action do we see? It's not as often as we'd like. But this report kept it real simple. It was a big report, but at the end, they came up with a number, right? And that number made it the 8th leading cause of death, and another million are injured. And so, yes, we can all argue about their methods and their extrapolation from the studies they had, but that made a huge difference. It was a simple message. Remember, I talked about practicality? This could be understood, medical errors. And so that keeping it simple is a really important part. But again, how did that simple message really have its impact? Again, broad press coverage and congressional hearing. And here are just some of the initial results that happened. There was an executive order. HRQ, I was there at the time, was given all new authorities around patient safety. I wish they'd been given additional money. But not only was there all kinds of new initiatives in the public sector, but the private sector, whether it was the Joint Commission or others, also started to act. And here's where I want to mention the point about keep it simple, stupid, and know your messenger and your message frame. The words you use matter tremendously, because in Washington, at least, depending on which word you use, people will use that cognitive shortcut and put you in the liberal or conservative camp. And so you need to know and be careful how you craft your message and the frame you're using. And so those are just some examples based on a lot of research, again, about being clear about the frame and the message that you're using. The third lesson, and I have 3 minutes left, the third lesson is about the timing. You may have all heard that this window is about the policy window of opportunity. If you're interested in this topic, go back to one of the classics. First I think Kingdon published it in the 70s, but it's been re-upped more recently, where he talks about the garbage can theory of policymaking, and the window opens and people just reach into that garbage can to find potential solutions. And so it's the alignment of, appetite, problem understanding, and existing solutions based on evidence that can then, if you're lucky with the right timing, lead to opening that window. And there are different ways of opening that window. Sometimes it's a predictable event. Budgets. You know that budget is going to come around. So have your evidence ready to inform the next appropriations debate, whether this is federal or state. A focusing event, the death of a prominent person, or an error happening to a prominent person, or to the loved one of an elected official, that can cause that window to open and suddenly policy to move that you've been knocking your head against the wall for years. And then again, the role of individual champions, both among the policymakers, but also in researchers. And here's an example where timing was critical. Another impact awardee was Linda Bloomberg and her colleagues, who produced a whole series of reports around the Affordable Care Act and the mandate, and the tax credits, and they showed the impact of eliminating the tax credits and cost-sharing reduction, the characteristics of those losing coverage, the impact on providers, very important, not just the patients. You need to lobby all your coalition to come forward, so the impact on providers and individual states, again, making clear to states what they're going to lose. And the timing, again, was critical at the point, because they had it in time. The briefs were written to be broadly understandable, on time. They underscored the degree of impact, and they were incorporated, because of the timing, into the legal briefs. And so, bottom line, they really influenced the Supreme Court decision, and Chief Justice Roberts even mentioned them and their work in his decision. So, very important, being Johnny on the spot, Jane on the spot with your research can make all the difference. So learning to play the long game is something I've also learned. When you're a pediatrician in clinical practice, I always used to say that, kids get better almost despite you. They have all these acute self-limiting illnesses, and, you're not going to do much for them, just, help their parents. And of course, we've got growth in chronic conditions, so pediatrics isn't that simple. But you really are looking at the long game for kids and their developmental trajectory. Well, it's the same in policy. And I love this quote from Warren Buffett. You can read it yourself, but you've really got to think, what difference can or will you make 10 years from now? And so my example there is a personal example. The State Child Health Insurance Program was reauthorized in 2009, 2 years after it lapsed in 2007, and it was one of the first bills that President Obama signed. But we knew, and the new bill had policy changes in it which were based on studies that documented the impact of CHIP on access, quality, outcomes, and disparities, all the things that it was supposed to improve, the initial legislation. And it also identified the importance of continuous enrollment, not just getting kids in, but keeping them on the program. And so how did this come about? Well, when the legislation passed in 1997 and I was at AHRQ, I said, we're going to have to evaluate this. We know it comes up in 10 years for reauth. We got to have the evidence for it. So we earmarked some money in our budget. I worked with partners at HRSA and at a foundation. It led to a $9 million initiative. We timed a special issue of Health Affairs. We worked with advocates. I was not a Fed at the time. I was not at Academy Health at the time. We don't take positions on specific legislation, just science policy, just to make that clear. So I only advocate for science policy now. But that really helped. And so seeing that 10-year window, getting ready, and having that long view. The fifth lesson is building the trusted relationships. Too many researchers, and me included when I started, I have this great finding. This is really important. Use it. Here, take it. They have to get to know you. Do they trust you? Because if they trust you, they'll trust your data. And how will they learn to trust you? Help them. What are their needs? Respond to their needs. Be available. And then that trust will be built up. And so you serve as a resource. And if you ever get into the advocacy space, which I have been, make sure you know which hat you're wearing. Because once you choose to go beyond just here's the evidence, thank you, ma'am, to here's the evidence and here's what you should do about it, if the word should is in there, you're crossing the line into policy entrepreneurship. That's fine. Just know where you are. And then importantly, knowledge brokers. Those folks who sort of live in between. I sort of feel I've spent quite a bit of my life in between research and action, research and getting somebody to do something with it, because you've got to understand the drivers and cultures of both worlds. I grew up overseas, so it's probably that I've just always lived out of my element. And don't forget that change, and policy change included, happens at the speed of trust. So you've got to build those relationships. And the final lesson learned is use the power of narrative, i.e. qualitative research and stories. Mixed methods are incredibly important because your data make you credible, but as I said earlier, everybody has data these days, right? They all have their evidence. So come with your data, that's a necessary, but it's not sufficient. Come with your stories because they're going to remember the story. You're going to connect with them on an emotional level. And again, cognitive science, everything we know from research, that's what makes you memorable, and that's how you are more likely to have an impact. And for me, I'll tell you my story. Why is all of this personal? Well, there I am, pregnant with my twins 18 years ago. There they are. I had breast cancer during pregnancy, and data and research inform my therapeutic choices during my pregnancy. And so I use this story when I talk about the importance of research in healthcare. Again, use your stories. If you have a family story, a personal story, a patient story, bringing those stories forward in your work to inform policy is absolutely critical. So I would end just by saying that evidence matters as it always does, but maybe now more than ever. Or to use the words of our former vice president speaking at one of our events, what you do matters. It matters. It's a matter of life and death. Thank you.